History of United States Healthcare by Heather Waterland, HCA 205, Introduction to Healthcare. Good evening. My name is Heather Waterland. I have been a community health educator for nearly a decade. I am also a nurse for nearly 20 years now. In just that short time span, I have seen the drastic changes that have come with each new year. Through this presentation, I will look at the history of healthcare in the United States, major events that led to healthcare as we know it today, and I will also look at the future. The 1920s ushered in many firsts for Americans, from the invention of the automobile by Henry Ford to the Band-Aid by Errol Dickinson, but few things made more of an impact than that of our U.S. healthcare system, which came to life during the 1920s. Prior to the organization of the system we now have, healthcare consisted of doctors making house calls to the community at large. If a member of the household was sick, they would be quarantined to a section of the home. The doctor would arrive, evaluate the patient, and give instructions. For most doctors, they were not paid in cash but in services. For example, if the man of the house was a skilled tradesman, like a woodworker, he would offer services to provide in exchange for medical care. Many diagnostics like blood draws and checking urine could be done at the house. They could also do moderate to moderate surgeries in the home. General anesthesia was not widely used at that time, so surgeons were limited to the patient's ability to tolerate pain. Hospitals were not the greatest place for patients at the turn of the century. In fact, they were known to be filthy and a major contributor to the spread of disease and bacteria, along with doctors not washing their hands when going from one patient to another, nor did they know not to do that at that time. Home visits reduced and hospital stays became more prevalent towards the end of the 1920s, in large due to more hospitals around the country beginning to follow a plan started by the Marine Hospital nearly 120 years previous. The first Marine Hospital is documented as being one of the first publicly funded, prepaid insurance programs in our nation's history. President John Adams signed the Marine Hospital Fund Bill into law in 1789. This law guaranteed care for members of the United States Merchant Marines, the U.S. Coast Guard, and several other members of government agencies. The Marine Hospital is so significant to modern healthcare because the foundation of most today's programs come from the Marine Hospital model. Fast forward about 100 years to 1847, when the American Medical Association was formed. Prior to the AMA being established, doctors were truly practicing medicine. The AMA was formed to create a standard of practice for all practitioners across the country. The first code of medical ethics was established. Standards of education were also set, thus changing the level of care in the U.S. forever. The American Medical Association states, "The AMA represents the best of American medicine and today continues to serve as an advocate for the profession, physician, and patient." As we enter a new century, the tools and foundations for successful healthcare are present in terms of care, but paying for this care is still a major issue. President Franklin Delano Roosevelt and the Great Depression put into motion better ideas to accommodate healthcare needs of all citizens. Franklin D. Roosevelt was the first president to speak out and say that all citizens are entitled to healthcare, and has been a hot-button topic with every president to follow. FDR attempted to pass a universal healthcare system, but unsuccessfully settled for the establishment of Social Security system. For as great as the Social Security system is, it did not address the medical needs of our country. With a failed attempt at national health care, another door opened: private insurance. On the campus of Baylor University in 1929, a group of teachers came together to brainstorm and form the first private healthcare company, Blue Cross. The concept was to pay a fixed rate for a set number of days in the hospital. This model of insurance would lay the foundation for every insurance company that came after it. You can fast forward to 2015 and still see this plan, but with twists, being executed every day across the country. An industry standard model, DRG, or Diagnostic Related Group. For example, an insurance company negotiates a set price to be paid to the hospital for the care of a patient with specific diagnosis. DRG is the most common of contracts set between hospitals and insurance plans. As we move further into the 20th century and private insurance is up and running and available to more and more citizens, focus changes from funding to care and quality of product. Questions start rising about quality of care. Essentially, are the insurance companies and patients getting the most for their hard-earned dollar? In 1951, the Joint Commission on Accreditation of Hospitals, JCAH, was formed. Up until recently, the organization was known as JCAHO. The O, standing for organization, was added several years later to include urgent cares, doctors' offices, and independent surgical facilities. Now known just as Joint Commission, it was established to evaluate health organizations, regulate and manage care that is being provided. In addition, the Joint Commission has set industry standards for every hospital in the country. A patient should be able to walk into any of the 21,000 Joint Commission accredited hospitals and see the same standard of care at every facility. The standard of care set by the Joint Commissions directly affects the social aspect of medicine and our patients. As the Joint Commission demands more, our patients are demanding more. Patients are more aware than ever of the rights they have as patients, what the minimum standards of care are, and what mandates are in place not just for providers, but facilities like doctors' offices and hospitals. Now more than ever, patients do their homework before they come to the hospital or doctor's office. They are researching providers, looking for open legal cases or bad reviews on social media. They also look for the latest in treatment plans and cutting-edge advances related to their disease process. Joint Commission takes care of the quality of care and delivery of care, but a nagging issue still loomed in the background. Not every American was receiving health care. Young Americans were having no trouble getting private insurance, but our senior population, over 65, was being turned down by companies like Blue Cross and Blue Shield. In July of 1965, not long after taking office, President Lyndon B. Johnson and Congress created Medicare, giving medical insurance to anyone 65 and over, regardless of income or medical history. Medicare is a social insurance program that spreads financial risk across society as opposed to a private insurance that adjusts prices according to perceived risk. Besides coverage for inpatient and outpatient services, the program has expanded to provide payment for prescription drugs, to cover younger people who have permanent disabilities, to cover individuals with end-stage renal disease, and to provide for hospice care, as defined by the Centers for Medicare and Medicaid Services in 2013. With the creation and implementation of the second and third-party entities that have access to patient records and sensitive medical reports, the question of patient privacy arose. How would we keep the private information from becoming public knowledge? With the technological advancements happening all over the world and the ability to obtain and pass information on almost every imaginable topic in every person in the world, safeguards needed to be met. As the medical community pushes forward and towards the end of another 100 years, HIPAA, the Health Insurance Portability and Accountability Act, is created. The primary goal of HIPAA, which was enacted in 1996, is designed to provide privacy, standards to protect patients' medical records, and other health information provided to health plans, doctors, hospitals, and other healthcare providers. When HIPAA was first introduced into the community, the pushback was large, but hospitals were quickly realizing that the law was not going anywhere. Most medical corporations, whether doctors' offices or hospitals, have a HIPAA compliance officer that is dedicated to making sure their facility abides by the rules and regulations associated with this law. As you can see, the late 19th century and the majority of the 20th century were spent creating, molding, and modifying our present-day healthcare industry. The world of healthcare is large, and it takes so many people to make the gears run smoothly. Those people would be our stakeholders. Stakeholders are a combination of people from patients to healthcare professionals, i.e. nurses, doctors, pharmacy techs, social workers, just to name a few. Healthcare professionals view quality in a technical, performance mind. Doctors and nurses are looking for accuracy of diagnosis. If the right treatment plan has been ordered, they measure this by the resulting health outcome of their patient. The next major stakeholder would be the patient. Patients want compassionate, empathetic care from providers. They want providers with skills, but yet clearly communicate throughout the care process. Hospital employers are another group of stakeholders. This group walks a tightrope every day. They want to keep their costs down, provide excellent patient care, and provide excellent benefits and support to their employees. Last but not least of the primary stakeholders would be the payers. Their job is all about cost effectiveness. Payers tend to see medicine in a very black and white picture with very little gray zone. Payers want providers to adhere to evidence-based, precise diagnostic plan and reach a treatment plan with the fewest visits and least number of tests done. The biggest discord amongst all stakeholders is that of the provider and the payer. The provider wants treatment to treat the patient regardless of cost to the patient or the hospital as long as they fix the patient. The payer group wants to do all of those things but with the least amount of cost. The 21st century brought several types of reimbursement programs: fee-for-service, capitation, pay-for-performance, and value-based healthcare. Fee-for-service method is used mainly by private insurance companies and some state Medicaid programs. They negotiate a predetermined price for each test performed on a patient. Fee-for-service is the oldest model of cost reimbursement. This method of payment pushes the envelope by encouraging physicians to order more tests that may or may not be necessary. This is a prime example of quantity versus quality. Capitation, the second form, is where a provider and a managed care program negotiate a contract for a set amount to be paid per patient for a certain amount of time, regardless if the patient seeks care in the amount of time or not. The American College of Physicians stated, "Capitation payments control use of healthcare resources by putting the physician at financial risk for services provided to the patient." Many medical groups participate in this reimbursement program. The third option is pay for performance. This is where doctors receive incentives for giving exceptional care. The model of payment is aimed at incentivizing providers to produce quality care while being efficient and cost conscious. This method is pretty popular amongst payers like Medicaid and Medicare, according to Health Affairs of 2012. The final reimbursement option is value-based in healthcare, which is gaining ground in popularity. This cost program was created to improve quality of care and reduce costs. This is the quality answer to the fee-for-service quantity answer. This cost model encourages the provider to perform quality assessments and only order exams and procedures on an as-needed basis. The value-based model works well with the ACA, the Affordable Care Act, goal of emphasizing preventative care and appropriate treatment plans. Each program is used differently based on the company's goals and needs. That being said, they all have an important role in the structure of the medical community. Now that we know how services get paid for, we will evaluate how certain services can affect cost. The medical community would not be where we are today without the technological advances having happened over the last 100 years. With the discovery of X-rays by William Röntgen in the late 1800s and refinement of them by the 1920s, and vaccines like measles mumps vaccine in the 1970s, the cost of providing care has gone up dramatically. But can we really put a price on those discoveries? The care that the medical profession has been able to provide with the discoveries is invaluable. We have been able to treat injuries like broken legs and diagnose the most minuscule tumors with the use of radiograph. The number of children and lives saved and pandemics prevented with the discovery of vaccines, not just the measles mumps, is nearly impossible to gauge. Medical research and pharmaceutical companies have researched endlessly to generate medications to cure life-threatening diseases or extend the life of a loved one with a terminal illness. Unfortunately, in order to have these advancements and continue to find new ones, there has to be funds. The cost is passed on to the patient through copays, deductibles, and insurance premiums. These discoveries and many more do add to the cost of care, but the quality of care that they help provide is priceless. For all of our discoveries and inventions, the United States sadly does not rank high worldwide for healthcare. Despite having the most expensive healthcare system, the United States ranks last overall among 11 industrialized countries on measures of health system quality, efficiency, access to care, equity, and healthy lives, as noted by the Commonwealth Fund of 2015. Our neighbors to the north, Canada, have a system that is only slightly better than ours at number 10. Canadians apply for insurance by applying for a provincial health card. This is done by most citizens, a few exceptions being armed services, the Royal Canadian Mounted Police, and incarcerated citizens. They have a law similar to Obamacare that they call the Canadian Health Act, which requires all residents of a province or territory to be accepted for health coverage. There is a waiting period for people immigrating into Canada of no more than 3 months to obtain health coverage. Healthcare is funded by several sources in Canada at both the provincial and federal levels. Taxation of both personal and corporate entities is one source. Another, funding from sources like sales tax and lottery proceeds. Canada does have their fair share of pros and cons related to the healthcare system. Canada's healthcare system is the envy of many other countries and their citizens around the world, and like other members of organizations for economic cooperation and development, Canada is under pressure to reduce healthcare expenditures. De Rosario, 2011. The overall services the country provides is above average. Canada offers the same services for the most part as the United States. One item that is unique to Canada is that patients over the age of 65 that have end-stage renal disease are not eligible for dialysis. Many patients will try to get to the U.S. for treatment. A pro for Canadian health insurance is that whether you are extremely wealthy or living in poverty, the care you will receive is the same. A con is the time delay in care. Many citizens complain of the extensive wait time to see a provider or have testing done. Canada and the United States, as you can see, share common ground on some things, and on others, the United States still lags. The United States has initiated the Affordable Care Act, which is started and in place, but is still yet far from total universal care. Canada mandates and has universal care for all of their citizens. One of the biggest practices between hospitals and insurance companies is diagnostic-related groups. The vast majority of American hospitals also use DRGs. The same for Canada. Hospitals will set contracts for payments by diagnosis from the federally funded insurance program. North America has two powerhouse countries that even after 100+ years of practicing medicine are still practicing medicine. As we move into the 21st century, the medical community is pulling off the rose-colored glasses and looking towards on how to fix the proverbial hole that has been created. Today, there is a new openness to changing a system that all agree is broken. What we need now is a clear national strategy that sets forth a comprehensive vision for the kind of healthcare system we want to achieve and a path for getting there. New England Journal of Medicine. The United States is slowly turning the chapter, putting focus back on the patient, creating programs like value-based reimbursement and incentive programs to get providers back on track and caring for the whole patient and not looking at them as dollar signs or breaking them down by disease process. One improvement that has taken off and seems to be becoming more common is that of patient-centered medical homes. This program is where all care runs through the patient's primary care physician. The idea is that the patient is receiving services when they need to, as well as get to specialists when needed as well. This program is also a win for managed care. By having one provider as the leader, you do not have multiple doctors ordering the same test, thus reducing redundancy and cost. Another aspect of reform that has forged ahead is the 21st century of sharing information. We live in the information age. We have the world at our fingertips and the stroke of a keyboard. For years, companies kept their strategies a secret to keep ahead of the competition, but that is changing with the help of resources like Health System and Reform Journal. Each issue of HS&R will include research articles and commentaries on the crucial issues in health system and reform, along with policy reflection from a healthcare leader such as a current or recent Minister of Health or a leader in industry or the nonprofit sector. Quoted from Health and System and Reform, 2015. As you can see, the 19th and 20th centuries have been a whirlwind of change for the healthcare industry, and the 21st century is falling right in line. Every day we hear of amazing new technology, medication advancements, and how the community is moving more towards the patient-centered care. I believe in 10 years, patient-centered care will be the gold standard across not only the United States, but other industrialized nations that are struggling to find their stride. The medical community will pull away from silo care and use technology to provide care that has input from every corner of the world. I also think that the balloon on cost will pop, and we will see a drop in the cost of supplies and equipment, which hopefully then will reduce fees charged by hospitals and physicians. This concludes my presentation on the U.S. healthcare system. Thank you.